association. Somebody with episcleritis will have mild pain, but somebody with scleritis will have deeper bearing pain inside the eye. Scleritis, which is the more severe form that patients with rheumatoid arthritis can present with, can progress to necrosis and subsequent perforation of the sclera, and again loss of intraocular contents in sight. The image on the right-hand side shows you a whitish nodule, and this is a picture of necrotizing scleritis, also a severe form of scleritis that is seen in patients with rheumatoid arthritis. This particular slide shows you a condition called scleromalacia perforans, or melting of the sclera, again, coat of the eye. The important point to note here is that you can have a situation where the eye overall looks deceptively white or clear, but it can have an underlying problem that is sight-threatening for the patient. So it is really very important to ask your patients what their problems are in terms of their eyes, and to really sometimes even just carefully look. If you see that something is there that is not normal in appearance, that where the pigmentation is different, or it appears to you that this is different than your own eye, I think it merits an evaluation. In individuals with rheumatoid arthritis, you can also have a peripheral corneal melt where the epithelium breaks down, the stroma below it breaks down, and you can see there in the particular slide where on the cornea you can see a divot or gutter-like ulcer. Left uncontrolled or untreated, this is then going to also develop into perforation and loss of vision inside the eye. Individuals who present with this kind of a problem, where they present with peripheral corneal ulceration, very often have a potential of developing ileal systemic vasculitis. And so I think the time between the rheumatologist and the ophthalmologist is very important. Should an ophthalmologist notice this, it's very important that they should refer the patient to a rheumatologist as well. Juvenile rheumatoid arthritis is another problem, and the most important thing that I want to really talk to you about is the fact that in juvenile rheumatoid arthritis, the eye can again look deceptively white and normal appearing, and yet with a very normal externally appearing eye, you can have an eye that has havoc that's been wreaked inside it. So it is truly very important that for all your juvenile rheumatoid arthritis patients that they get into a routine screening program, whether they complain to you that they have any eye problems or they do not, because very often, within the context of just looking at their eye, you will not be able to tell that something is going on. You need to be absolutely screened. And I'm not going to really talk to you about the post-articular-form or the rheumatoid factor negative, because you know a great deal more about that than I do. So it's also important to realize that when you have ocular manifestations, they don't necessarily mimic the stage of systemic disease. So sometimes your ocular manifestations for disease can be much more severe than the other systemic manifestations. In terms of juvenile rheumatoid arthritis, we think of a classic triad being the late ocular complications of GRA. And if you can look at the slide on the image on the right-hand side, you can see that the pupil aperture looks to you to be not normal. There is a small area that's indented on the upper right-hand image. And this is what we call a posterior synechia, or a degree of attachment between the iris and the lens itself. This tells us that previous episodes of inflammation have occurred. You can also look in the middle image where you can see the white area coming on into the cornea. This is the beginning of band keratopathy, or calcium deposit in the cornea, which is a response to ocular inflammation. And then finally below, you can also see on the mapping at the third of those images that you see again a whitish band coming all across the cornea. And below that, behind that, you can actually see behind the iris that there is a cataract, a white cataract. The image that is directly at the 6 o'clock position shows you an eye that again looks very deceptively white. I don't have the pointer. It's not working actually. Here, this is. No. It's just no. One moment. There we go. So here is what you're looking at, band keratopathy, which is the whitish area. These are calcific deposits. You're looking at a cataract here. Okay, and you're looking here where you see that the iris and you're looking at the pupillary margin is not regular. There is a bit of synechia present. This eye, if you were to look at it in clinic, I'm sure you would say, looks like a fairly normal appearing eye, except for this very, very small grayish band over here. But this is an eye that actually, when you look at in terms of clinical examination, presents many of these features. So very often the important point to remember is that the eye can look really deceptively white, but it really needs to be examined, and that disease needs to be controlled and managed for the patient. iritis in juvenile rheumatoid arthritis patients, much as we talked about iritis and ankylosing spondylitis and other diseases, is present in almost 15% of patients. There can again in children be very few symptoms of and this is different than the adult population. They can develop long-term complications again, such as cataract and glaucoma, and this is important to remember. In individuals with cardiovascular diseases such as lupus, you can also have several ocular manifestations such as dry eye, which is a very common feature. You can have scleritis, peripheral corneal ulceration, and retinopathy and optic neuropathy, which is the most common severe manifestation. Here in this particular slide, you can see that the retinal vasculature is affected, leading to the presence of corneal spots. You can see hypertensive retinopathy, which you can see because of neural involvement. And finally, in the slide down below, you can see that the optic nerve is not normal in appearance. You don't see the clean margins that you are normally would if you looked into somebody's eye. This is ischemic optic neuropathy or an infarct to the optic nerve head. So sometimes patients with SLE will report to you a sudden change in their vision, and it's very important to take that more seriously. In conditions such as polyarthritis nodosa also, there is a commonality with dry eyes, corneal ulcers, scleritis, hypertensive retinopathy, and retinal vasculitis. So really what I want you to appreciate is the degree of intraocular inflammation that is common to these diseases. Another disease that you tend to see and you can see as well is giant cell arteritis, and I'm not going to go through the systemic symptoms except that realizing that acute visual loss is a fairly common manifestation of giant cell arteritis. And individuals with giant cell arteritis, again, like individuals in SLE, can present with